Good morning and good afternoon, depending on your time zone. Welcome to our webinar, Championing Population Health Beyond COVID-19, a Roadmap for Payers. My name is John Piggott. I go by JP, and my responsibility with Innovacer is the Managing Director for our Payer and Life Sciences business sectors. And I'll be your moderator today. I'd like to introduce you to our panelists. First of all, I'd like to introduce Beth Bierbauer, former president of Group and Specialty Division at Humana. Welcome, Beth.
Welcome. Hi.
And Mike Sutton, who is Chief Technology Officer here at Innovacer and former CTO at Kaiser Permanente. Welcome, Mike.
Thanks, JP.
Okay, our agenda today is we're going to explore a number of different topics and discussions. We'll talk about the landscape during COVID-19 pandemic across healthcare. We're going to talk a little bit about change in some of the payers' processes that were in reaction to that. And then there's three main topics that we'll address during the course of our discussion today. First of all, the trend in growth in Medicaid enrollment and repercussions with that. We'll talk about the implementation and adoption of virtual care or telehealth, and then we'll talk about the CMS regulatory interoperability requirements and get into a discussion around that. At the end, we'll wrap up with a bit of a Innovacer Care as One infrastructure, and then the healthcare data platform approach for payers. So really look forward to the conversation and the discussion. One of the things that I wanted to point out is during the course of our discussion today, if any of you have any questions, you can submit those in the chat, and we will attempt to address as many as we can, time allowing. So please, if you have questions, submit them in the chat, and we'll get to those. Okay, so first topic of discussion is COVID-19 and some of the changes in payer processes. Some of that COVID-19 crisis highlighted the needs for some different approaches. One, expanded analytics and insights into what's going on out in the market. Specifically, some social determinants of health insights to address member access issues. And then some prospective and prescriptive provider and hospital-related analytics around handling the surge. And then expanded utilization reporting to assess member needs and adjust benefits and coverage accordingly. Beth, I'd be interested in some of the insights that you have on what you've seen from a payer's perspective as they address this this really once in a generation type of crisis.
Well, sure. Thanks, JP. I think you highlighted some of the key things, but what's really important for payers during this time is making sure that members had access to care, and not just from the standpoint of the fact that maybe provider offices weren't available, but just also that they continue to monitor those people with chronic conditions, that they were able to get their medications, that they were able to get access to the care that they needed. And then the other thing that you mentioned also with social determinants was really important. A lot of people feel very socially isolated these days, especially the vulnerable population, the elderly population who cannot get out, who will not go to the grocery store, should not be going to the grocery store. So from a payer perspective, analytics is really needed to understand who your most vulnerable population is, and then what are the services you can bring to bear to help them at this time.
Very good, thanks. Some great insights. The next chart I want to talk about really is this trend here. It looks to me, based on this data, and we can debate it, and I actually do want to debate it a bit. certainly we had a significant decrease in paid claims for inpatient, outpatient facility during the COVID crisis. Nobody was coming in for any kind of elective surgeries. Nobody wanted to go to see their doctor for anything. Nobody wanted to get close to a hospital. But we've seen a gradual increase back to the point where, according to this data, we're seeing a bit of a surge. And I'm just curious as to your opinion. I'm wondering if what we're seeing is a bit of a surge in people coming in for elective procedures, and that will eventually normalize to normal levels. Beth, what do you think?
I do think that we are starting to see some people come back and get the elective surgeries. If you'll remember, elective surgery actually had some pretty broad, it was a pretty broad category, if you will. At one point in a certain city, it included people that have been diagnosed with cancer that were not able to get some surgeries and some treatments that they needed. So it was pretty broad. So certainly some of those things are coming back more rapidly than others. But even if you think about things like cataract surgery and other things like that, at some point people are going to need them. The other thing I would point out, JP, is what's really in this utilization. Yes, I do believe people have been returning somewhat to the office. A lot of visits are still happening through telemedicine. But there's probably a lot of testing in here as well. A lot of people are getting tested for COVID, and when you're getting tested once, you're often getting tested multiple times. So I think that's part of what's in here. And then the other thing is, I was just recently talking to somebody that mail order pharmacy utilization has increased dramatically as well. So we're probably even maybe seeing a benefit here, some increase in that type of utilization and medication adherence. So I don't think it's necessarily a one-for-one that was what was to take place before is taking place now, but I do agree that it is returning a little bit closer to what we would have expected to be happening at this time.
Yeah, very good. Mike, you have any thoughts on this? What have you seen? You're sort of a specialist out in California. Anything that you're observing?
I think, so I'll speak more from a technical perspective. And so I think, one of the, not that there's any silver lining in the pandemic, but from a technology perspective, many of us have implemented, the telehealth, the virtual visits. A lot of technologies have been put in place, way long before, COVID-19 hit. And I think what happened was, I think people saw how effective it was during these dire times, and you couldn't go in. And so, and we don't expect that to dip too much. I speak to a lot of healthcare professionals, and one of my first questions is, from the video visits and telehealth visits, what's your feeling on that? And it's almost overwhelmingly that, of course, there are people who are going to want to go back into the visit, but really the change management, which has taken really years and years to get to, happened in a very short 3-month period during COVID, where telehealth adoption, I can speak to, the systems that we had put in place at Kaiser went from, roughly 1,000 a day to over 40,000. It probably is not going to stay at that level, but it's not going to decrease 40 times. And I think, this crisis has shown how valuable this can be. And I don't think it's going to reduce, a bunch. It's going to come down a little. And then the second point, you mentioned analytics, is, I think it played out in the media. We saw it in the news. Is there really is a reporting problem in the healthcare industry. We couldn't, as an industry, answer some basic questions like how many beds were available, how many ventilators were available, and there were people, struggling. The government, HHS, was asking for that, 17 pretty simple data attributes to be filled out every day by providers. People struggled to produce something as easy as that. So I think it's also highlighted a need for better data integration in the payer space and provider space, which, we're starting to see a lot of interest in as well, at Innovacer.
Yeah, very good. And we're going to explore a little bit more depth the telehealth angle that you brought up later in our webinar today. Okay, so those are some interesting observations, and kind of, I think that the green line would be kind of what I would have expected to see. but I'm not sure we're out of the woods yet. Every time we've seen states begin to open up, we see spikes. So it's interesting, and actually the latest observation that I had was, or I saw, was that people can, they're concluding that immunity may only last a few months, which is potentially alarming as well. So anyhow, let's continue moving on. I think we actually have a poll. We'd love to get some feedback from the audience. So our poll, our first of two polls, is that the question is, what impact has COVID-19 had on your organization? Is it an overall reduction in number of claims processed, reduction in elective surgery procedures, reimbursement changes, increasing out-of-pocket expenses, increase in behavioral health usage in claims? So be interesting. We'll open that poll, and we will we'll give it a couple minutes for people to respond. But in that meantime, Beth, I talked about a little bit about the most recent observations that perhaps the immunity is short-lived. What do you think that will do to the trends here?
Well, I think that from a health plan perspective, they're really going to have to start to look at their financial planning a little bit differently. Look at the possibility of not just a resurgence, but a resurgence now understanding that, gosh, if you've had it before, you can possibly get it again. And like you, JP, I just read something about somebody that had it and now has it again. And there's still a lot more to learn about that, but from a health plan perspective, we're going to have to be very, very thoughtful around how they plan for that, not only financially, but from an access perspective, working with hospitals, working with other providers. And again, until we can really get a vaccine, really understand all the implications from this virus, really the payers are just really going to have to figure out and make sure that they have enough arrows in their quiver, if you will, to be able to deploy whatever means they need to, depending on what's happening. But I think they just really have to be prepared for more to come. This isn't a once and done issue.
Yeah, I agree. That's a great point, and I think we are all as a population need to get used to this shelter in place process, at least until at which time we begin to see vaccines come out that can begin to address the issue. So very interesting. I'm not sure if we have a poll or results of our poll or not. Do we have any results?
So I don't know if you can you see them, JP? The overall reduction in number of claims processed, 69%. The lead is reduction in elective procedures, followed by the reduction of claims processed, and then increase in behavioral health, and then finally the changing increase of out-of-pocket expenses.
Okay, so overall reduction is the major
elective procedures first, and then reductions in claims processed.
Got it. Okay, yeah. So any observations, any surprises?
No, absolutely no surprises. I mean, the audience are people from health plans, so they know better than anyone, and this is exactly what I would have expected.
Okay, very good. All right. Well, let's continue to move on then. We'll transition to, as I said, there were going to be three areas of discussion that will center this discussion around for the webinar. The one is the trend in growth in Medicaid. We'll talk about that. Then we'll transition to implementation and adoption of telehealth, and then finish up with the compliance, the CMS compliance initiative. So first piece is the Medicaid. So here's our interesting graph. Beth, I'm definitely interested in your thoughts on this, but before I get to that, so this, just to interpret this, this is projecting based on various levels of employment, 15, 20, and 30%, the migration from commercial covered lives to non-commercial lives and uninsured. And obviously, the higher the unemployment, the bigger the numbers. But the interesting observation I had, Beth, is that it may not be as bleak as people think, or as this poll might represent, because in April, at the height of our unemployment, we were just under 15%. So the very first bar, the yellow bar. In June, it's dropped down to just barely over 11%, and in July, it's 10%. So it's starting to drop. Unless we see a major spike going on, and I think we've already gone through at least the first spike, this may not be as dire as it shows. Beth, what are your thoughts?
Well, as the economy starts to reopen up and people are able to return to their place of employment, I think that absolutely you'll see people have the opportunity to regain coverage, either through their employer or for those that may have been purchasing it on the exchanges directly. The other thing is obviously with Medicaid, you can see the coverage under Medicaid as people are no longer earning an income. They may be eligible for medical assistance, especially with the expansions that have happened over the last couple of years. So, the good news is that hopefully, we'll be able to make sure that people are getting access to care and getting coverage of some sort, even if it requires support from the government.
Yeah, for sure. And I think I'm going to explore that concept here in another couple slides. But the next slide actually shows a bit of a view across the country on what the growth in Medicaid has looked like. With the exception of a couple of spikes, Kentucky being the largest at 7%. Largely, I would say most increases have been in the 1% to 3% range. So, kind of the low end of the spectrum that we saw in that previous graph. But what I really wanted to explore here was this the challenge from the state level, in that as the employment has dropped, state revenues have dropped as well, while at the same time costs for Medicaid as the enrollment increased certainly have increased and have really creating a lot of pressure. Interested, Beth, in your thoughts around how are states going to manage this? What kinds of things can state Medicaid plans do to balance, or the states themselves to balance the funding of the growth in Medicaid with the loss of state employment revenues?
Yeah, that's a good question. I mean, many of the states are really going to face a dilemma, to your point, because enrollment in Medicaid has increased, and they work within a budget. So states are going to have to determine whether they have the ability to be able to shift some budgeting dollars around somewhere. They can also really work with the health plans. Many of those that are on the webinar today probably work with states with Medicaid, and continue to say the health plans, we're gonna have to squeeze you a little bit. You're gonna have to be as effective as you can as well in leveraging things like telehealth and other things to really be able to deliver low-cost care. So I think between trying to shift budget dollars where they can, some of them won't be able to do that, and then they'll just end up with a deficit, and working with their managed care partners, I think they're gonna just have to get creative. And then of course also make sure that they are optimizing every dollar that they can get from the federal government.
Well, and I did a little bit of research on this ahead of this webinar, Beth, and one of the other effects of this is that it may just increase the uninsured population, because the states aren't going to just be able to afford it, and so there's going to be this overflow, and we saw that on that graph a bit, in that the unemployment population is increasing as well, and that's at the sort of the dire highest percent unemployment ranges, and hopefully we don't get there, but it's certainly going to be a challenge to manage this and really control costs as much as possible. And as you said earlier, one of the avenues for doing that is telehealth, which can hopefully reduce quite a bit of costs, as well as provide better access. So that's what we're going to do now, is transition into the telehealth implementation and adoption. First of all, certainly there's been a huge, as Mike Sutton referenced, what he saw at Kaiser, there's a huge increase in telehealth claims from year to year, April to April, and the demand has rose tremendously, all driven by COVID, where people needed to see a doc but were unable to because places, the place was closed down, or were reticent to do that because they didn't want to get close to a healthcare facility with so many COVID patients prevalent. So huge increase, pretty widespread adoption of telehealth across the country. As you might imagine, the Northeast are sort of leaders in this, driven by the density of the COVID outbreak and issues in the New York area. But by and large, across the country, the adoption has grown tremendously. So, Beth, what are your thoughts about this trend?
Well, and full disclosure, I am on the board of the American Telemedicine Association, so obviously I'm a big fan of telemedicine. But here's the issue. It's been around for 80 years. One of the key reasons for slow adoption was my provider wasn't using it. And most people, when they have an issue, when they're ill, they need urgent care, they want to pick up the phone and talk to the doc. They want to go to their doc. And if your doctor didn't have that capability, well, then telehealth wasn't then on top of mind. You were thinking about that urgent care that you passed on the way to work every day for the last 5 years. Maybe that was open, or a minute clinic or something like that. Once doctors have now adopted telehealth and people know that they can actually get to their primary care physician or their specialist via telehealth, what you're going to see people actually using it, number one. Number two, now that providers have actually tried it, they're going to say, if they're smart, what else can I be doing with telehealth to be able to help patients? So you think about remote monitoring that's available, and you think about access issues to specialties like cardiology. Well, will the cardiologist now say, hey, wait a minute, you know what? I can actually help more patients if I can put a certain cohort of patients onto remote monitoring. And that way it actually opens up some access for the providers that refer to me. So while I do think you may not see it quite at the high level, it is not going back down anywhere near where it was, because you now have the people that you were trying to access, your providers, using it, and then you're going to have really tech savvy providers that are saying, wait a minute, I'm leaving money on the table and I'm not tapping into all the capacity I have if I'm really not adopting telehealth.
Yeah, and I think that that combined with the fact that that states have implemented parity laws around reimbursement, and suddenly there's not a detrimental reason or a loss of revenue reason for a telehealth visit. That barrier has been taken away and suddenly opened up the floodgates. It's interesting. I have a personal story. I have a bad hip, and occasionally I need to go in and get a steroid shot. And each time that I needed to do that, I needed to go in first for a physical visit in the office, and somebody would come out with a clipboard and ask me a bunch of questions and say, okay, fine, now come back tomorrow for your shot. I finally pushed back and I said, why do I have to come into the office and waste a half a day just for somebody to do a clipboard checkbox? That seems to me that you could do it over the phone, and then I only have to come in once. And they said, well, it's because it's a requirement of your health plan that they say you have to come in person. And it was quite frustrating personally for that. But I think now those kind of barriers are gone.
Yeah, I think you're right. And I know we have health plans professionals listening in on this. So there's one thing I'd really like to share with them is that when we think about telehealth, what we're trying to compare it to is a physical visit where you're touching somebody. And I would say when you really think about telehealth and you're thinking about your policies and practices, stop thinking about what you're not doing and start thinking about what is taking place on that visit. Because as the technology continues to advance, we're going to be able to collect more and more and more data, not only similar to what's in the office, but probably even more than what most people are collecting in the office. So I would just encourage everybody to really have an open mind towards the possibilities, because this really is an opportunity for us to reimagine healthcare.
Yeah, and
I think that's a. I was just going to add, JP,
to this slide, Mike.
Hello?
Go ahead, Mike.
I was just going to emphasize on Beth's point about, kind of integrating with the data, because, like I said before, for sure adoption is going to stay, but a lot of what we're seeing is, kind of the next round of the telehealth solutions is kind of number one on the list is collecting more and more of that data that happens at that time and getting it into the EMR. I remember when we first deployed our first version of telehealth, back in March, the very first question out of every clinician's mind and user's mind was, well, how does this integrate with my EMR? So we've got a long list of kind of, changes to do better integration and more collection of analytics at that point of care. And then secondly, I put the second category of kind of requests that folks are having is around simplification of the interface for both the physician and the member. And we're getting to the point now where it really, you've seen it with other apps, you've seen it with your FaceTime type solutions, is it really should be one click. And that's all really as simple as it is. But behind the scenes, there's a scheduling aspect, there's got to get the physician, at his desk or his or her desk at time for that. So there's a lot of work going on to kind of simplify that interface. And then the third category of kind of changes and requests I've been seeing is, as we rushed in, we had some loosening of some of the privacy requirements. Almost everybody categorically that kind of went in the case of, kind of picking an in-between solution, including, probably Zoom, one of the bigger providers, are doing a lot to get, the more robust privacy around that, because it is here to stay and privacy is non-negotiable. So I just wanted to add, those were kind of some of the things we're seeing as far as kind of getting broader use of the technology.
Yes, very good. Totally makes sense. And some of the messages here, about the payer-provider collaboration and coordination for care and medication adherence and management of chronic conditions are all being transitioned over to telehealth and using triage for assessing and caring for all patients to decrease the volume of people seeking care in the facilities, which actually helps in all cases. Okay, so let's keep moving. We're gonna transition now into the. By the way, before I transition, I understand we do have a few questions in the hopper right now. We're going to go through this and we'll open it up. I think we're going to have plenty of time. We'll open it up for questions. We'll address those questions that have been submitted here after we get done with the this subject. So okay, so the CMS implications of CMS compliance on payers. Really, a little bit of background first of all is that CMS actually finalized the interoperability rule in March of this year. And the rule really was part of a cross-agency My Health eData initiative started way back in 2018 to facilitate data sharing across public payers and provider organizations. So that was sort of the genesis of this. And this is not something that was new that came up out of the blue. This is sort of a concerted effort over time to provide access to data and transparency to clinical and claims data for patients and really for patients' convenience and access. There's four major components or pieces to the regulation. The first one being the patient access API, and that is to provide the patients the ability to access their data. And there's a deadline on that. Actually, the deadline was January 1 of 2021, but due to COVID and the disruption associated with it, CMS has pushed the enforcement of that rule to July 1st. So I know we're not working with a number of payers right now on standing up this kind of capability, and I think Mike will talk about that in a second. But the second piece is a provider directory API. Again, same date, July 1 for a start of enforcement, and that's the ability to expose your directory of providers that are available to patients. And then in the future, beginning January 1, 2022, there is the payer-to-payer data exchange, which is really in place to be able to, for a patient or a member that's changing plans and need to transition their data over to a new plan. And then the federal state data exchanges as well. That one is due April 1st, 2022. So a lot of regulations to abide by. A lot of people are in the planning phase right now, and will begin implementation, if not already, shortly. I'll turn it over to Mike really to address a couple of major considerations for this CMS compliance and things to think about as you prepare. Mike, you want to comment?
Sure, thanks, JP. Yeah, I'll start kind of from an architectural perspective of kind of where CMS I think has shown some leadership, and at least from a technology perspective is if you think about meaningful use and the digitization of all those clinical records, which took a decade easily, and there's still some people not all the way there. This is the next logical step of opening that data up and making it available for the eventuality of kind of putting the member or the patient in the center of their wellness. And so as we kind of progress into this phase of transparency of the data, what we're seeing, and as we're talking to folks, is that this is probably more complex than you actually think. Creating an application programming interface, an API, is not the most technically complex thing in the world. It's been around in many industries. We used it in the travel industry. Certainly the financial industry is using it, and we can easily adopt and try to get that availability and that transport of the data. But a couple things that are making it a little more complex is that you're going to want to make sure that your data is of high quality. You don't want to send the wrong information to your member, and they see that for the first time, because you'll lose their trust. And so this data in many payer systems is not coming from one single source. It's not as simple as, well, I have this one database and I'm just going to make that available. We're seeing sometimes 10, maybe even 20 different sources that have to be extracted to get the information that CMS has specified in those FHIR APIs. So we believe it's quite important that rather than just transmit that information and let the patient or the member sort out what's right and what's wrong, that needs to be done on the payer side. And so there's going to be a certain amount of data aggregation and quality checking that we think is very critical to make this whole FHIR API successful. Then also in the regulation, there's some complexities around consent. And normal consent is a fairly easy thing. JP, Beth, can I send the information for your health that I'm keeping for you as your payer? Can I send it to this third-party app? The complexities come in when perhaps you have delegates. Perhaps I may only want that permission to be for a short amount of time. Does it expire if I leave the plan and I move to a new plan? Does that consent expire? And do I have responsibility, being the payer, that my member is not sending their data to somebody that is not an approved third-party app that could protect your data with the privacy that we would? So there's a lot of responsibility items there, and there's different interpretations of the ruling on that. And then thirdly, and kind of related to the quality, is because there are people, healthcare is highly federated, there's many providers, many payers, many pharmacy systems and lab systems. We all have multiple identities at these places. And so when we bring this data in together and sort it, we need to be really sure that we're doing the proper identification before we send it to you, because nobody wants to have a mishap where the data goes to a wrong person because their name was the same as yours, but it's not you. So those are kind of some of the things we're seeing is some of the complexities in implementing this first phase of the FHIR APIs.
Yeah, very, very interesting and enlightening too. I know another element of the member consent piece is the granularity of that consent, and that they may consent to a certain amount of their healthcare data to be to send, but other pieces, behavioral or other sensitive clinical information, they may not want to consent to. So thinking about the granularity in addition to all those other things really makes it much more complicated.
Exactly.
So let's move on to, I think, our next poll, which is interested in your thoughts on the three initiatives below. What are your organization's priorities? Is it managing the Medicaid population? Is it enabling virtual care? Or is it focused on complying with the CMS interoperability mandates? Or is it none of the above? Interested in your thoughts. And Beth, actually wanted to engage you a little bit on this CMS compliance from a health plan's perspective. When you see something like that come down the pipe, what's your reaction as an executive from a health plan, and the things that you need to do to respond? What's your point of view on that?
It may not be easy for many health plans because as you know, and Mike probably really knows well, many health plans are old in terms of the companies have been around a long time, and they still have legacy systems, and data is stored in many different places. Now, obviously, all the major health plans and just many health plans have really been working very diligently to update their infrastructure so that they can actually get access to that data, but not only from a consumer perspective, but also because they want to use that data to be able to better serve their members. So I think it's going to be really important. I think it's going to require, in some cases, a lot of resources. But it may be sort of the kick in the pants that some folks may need, though, to really make sure that they are tackling this data aggregation issue in the right way, and that they can solve the problem once and for all, so that now they can really have a good foundation of data. And as Mike said, clean data, usable data that will really, that they can use, not just to serve to satisfy the interoperability, but now they can actually use as a business moving forward to help improve outcomes.
Yeah, so interesting. I have a couple of stories there. I recently moved from Chicago out to California, and you got connected up with a new primary care physician, and the process to go fetch my clinical records and bring them into the new practice is Byzantine. They basically fax a response back to the prior practice, and the practice prints off all this stuff and then they mail it out. And then I remember the story that Dr. David Nash, who's one of our advisors, was talking about, having some procedures done in his local Philadelphia market, and he couldn't get the two EMR systems that were of the same vendor, but just across town to even communicate with each other. They weren't able to do it. So very interesting challenges in interoperability these days. Mike, what were you seeing at Kaiser? I know that you guys were a little bit ahead of the curve at Kaiser in addressing interoperability issues.
And so and I would say, perhaps Kaiser, based, on its size, I think very early on, APIs are not just a good idea that came up from this interoperability. Is we based most of our architecture, and as Beth mentioned, some of our systems were older, but as we modernized them, we moved to an environment where there were these application programming interfaces and messaging between the multiple of different products that we had to integrate, to create a seamless environment for our members. And so fortunately, and again, kind of like where CMS's head is, APIs are not only a regulation, but they're just a good idea. And so we had a lot of them already in place and able to take advantage of as this regulation came out. And I will say probably one of the most complexities, and it's a little more detail on what we talked about before, was the different consent workflows that we had put together for the different states that we operated in, because not every state is interpreting the federal regulation the exact same way. And so we had to take each of our regions one by one as we did that implementation. And as well, we're seeing that with some of our customers that we're working with today at Innovator that operate in multiple states. So
yeah, it adds another complexity to it, doesn't it? Okay, I think we have our poll results ready, so maybe we could share that. And Beth, if you would, again, because I don't see it, just give me the breakdown.
Sure. So the top priority is managing the Medicaid population with 62%. Next comes compliance with the CMS mandate of 50%, enabling virtual care 46%, and then only 4% on none of the above. So no surprise there. It sounds like on the CMS mandate, maybe that's good news. It sounds like maybe some health plans have really gotten ahead of it.
Yeah, that's actually that's encouraging. As I said earlier, that people were either just beginning or in the planning stages. So more encouraging that we think that people will be able to be ready for those deadlines and yeah, interesting. I'm actually a little surprised that enabling virtual care was not as high of a priority. Thoughts on that?
Yeah, I have thoughts. Definitely have thoughts on that. I think oftentimes from a payer perspective, we think that virtual care is really between the provider and the member or the patient. And what I would really encourage people in health plans to think about is, how can virtual care help you do the things that you need to do differently? You have many people that interact with members, whether they're care managers, whether they're pharmacists, doing medication adherence. I would be spending a lot of time talking with telehealth platform providers and asking them, what additional use cases do you have out there for me as a health plan to start to actually think about virtual care? So I wouldn't think about virtual care as just an office visit, if you will. Think about all the different things, interactions and touch points you have where, quite frankly, laying your eyes on a member would be very beneficial.
Yes, thanks for that. Okay, let's continue to move on. I just have a couple more comments, and we'll get to questions. But one of the things I wanted to talk about is, we've explored a number of different trends going on, mostly related to COVID-driven, but really that highlights the need for data analytics, interoperability, and the ability to operate kind of in a environment where we can truly care as one with one infrastructure. And that's exactly what Innovator is doing. And what I'm depicting on this chart here is that fundamentally what we do is integrate with and ingest all the data in a healthcare community that is spread across a number of different systems. We bring it into what we call a data activation platform and create a unified patient record. And that serves as the fundamental foundation for a variety of solutions that are targeted at improving care, improving insights, improving optimization. We have a provider engagement tool. We have a care management and utilization management tool. We have a member engagement tool and the interoperability and regulatory API tools that we talked about. And then on top of all of that, we have advanced analytics and interactive dashboards to really illuminate and create the insights that are needed to really manage in this new normal that we're faced with. And so that's fundamentally what Innovaccer does to help address some of these problems. I'll ask Mike to talk specifically about this because it's a little bit back to the CMS compliance, and it's our healthcare data platform for payers to address that issue and those regulations. Mike, you want to talk to this?
Sure, JP. I won't go super deep on this, but I will kind of go one click down on this. And so, if you take that left-hand side, is one of the statistics that we collect on, we manage, close to the data for close to 12 million people within the Innovaccer, customer set. And on average, every member has about 800 entries against their health record. And they're distributed amongst many different systems. They may be in the claim systems or certainly in EMR systems. And then like Beth mentioned, the payers and the insurers have been around for a while. So they've created a lot of, very, very useful analytics in things like enterprise data warehouses, other reporting that they have to do. And so we consolidate all those records, and again, on average, 800 per person, which, as an individual with, with access to certainly a personal computer perhaps, but I don't know how to manage 800 of those records. So what we do is we take this data, consolidate it in this middle space where the data is put in the new FHIR format for the APIs, but we manage things like who do you want to look at your data? You may want if you're caring for an elderly person, you may have access to their data. We certainly authenticate that you're talking about the right person. A whole bunch of, and you probably, if you remember all the debates that were going on in March, that this API was going to, defy all the rules of privacy. APIs are very secure. And so the words like authentication on there and managing control lists are to ensure that privacy that can and will be protected by the proper implementations of these APIs. And then I mentioned third-party apps. Our solution is allowing for the payers to certify which third-party apps and not opening it up to every app. It's up to the customer on how they want to do it. But some people are saying any app can request the data as long as the member certifies it and says okay. Others are kind of taking an extra step of making sure those third-party apps are following the right security rules and regulations. And then thirdly, kind of on the right-hand side, is this data has become available again through third-party apps. We need to interact with the members to get their consent. Certainly, we think this environment for the payers themselves, because now there's a very rich set of APIs that the payers, developers and IT department can start building apps to help improve member, to improve the intimacy between the member and the brand, their brand. And we expect to see a lot of development in that. We provide a portal, a sandbox for people to help write applications in this new API-centered world.
Okay, great. Thanks, Mike. Appreciate that. Okay, let's move on to questions. And I know there are several of them, and I'll try to get to them as we go here. The first question is, and it's probably related to, Beth, it's probably related to the graphs around the migration to Medicaid. It says, does this take into account people may not be able to afford COBRA? I'm supposing that what they mean is that there may be a transition immediately to a Medicaid plan because they can't afford a COBRA plan, which would be part of their transition. What are your thoughts?
Absolutely, because when you're paying COBRA, today when you're an employee, you're paying a portion of the premium. COBRA is the premium plus, I think, 2% if I remember correctly, and that's pretty astronomical because many employers, especially larger employers, pay 75 to 80% of the cost of the true premium. So when that's on your backs all of a sudden, of course there are people saying, I can't do COBRA, I can't afford COBRA, I have no income, let me go see if I'm eligible over here for some type of temporary medical assistance or something like that. So good call out, absolutely right.
Yeah, very much so. Mike, I think the next question might be a good one for you. It says, and this I think is in regards to the CMS interoperability rule. It says, do payers need to present PDF medical charts in the patient access API? Good question.
Our understanding and interpretation is they do. And there are some medical record systems that are still, handwritten or in PDF version, and fortunately, we have the ability to take the PDF, and other providers can do this as well, of these data integration solutions. We take the PDFs, we scan them, and then we extract those structured records. So we can get them in the format to put as an API. And a secondary solution is also available that we just carry that PDF with the record, and they have the ability to send that type of blob storage to a member. Although I probably would not think that's the best solution. We believe that taking that unstructured PDF and converting it into a structured record to fit in the API message format is the best way to go on that. But we do believe it is in scope of the CMS regulation.
Yeah, okay, good. Another one for you, Mike. Question is, are these only 4 areas that payer have to work around the CMS mandate? And I'm not sure if I'm interpreting the 4 areas as the 4 regulations or the 4 components that you talked about that make up the innovation solution. Maybe you could explore both those angles.
Yeah, I'll tell you, and I think the answer is the same for both. I mean, this is the beginning. I think those 4 items in the CMS regulation, there's certainly going to be more as we go into the next version of these things. And as we know, the fire spec is on version 4. We certainly expect more to come around. And then I think the expectation is, because there is such, what's the right word? Separate interpretations of that CMS regulation, because it really is not as specific. It's not an implementation spec, it's a regulation. So we expect there will be some revisions to the regulation that will provide probably additional requirements and maybe some specification. And so if it's on the regulation side, I think this is the beginning. There's going to be more. And then on the second side is what we meant by those 4 is we think these are the priority items. I think there's a lot of things that have to be looked at as well, like archiving. Where do the consent forms go? I think there's a number of other items, but these are the ones that we kind of see as the most subject to interpretation and probably the higher priority. So, I think it's beyond the tip of the iceberg of what we've talked about today. Maybe we're a good halfway down that iceberg, but I think there's going to be more as this progresses.
Yeah, very good. And I've heard some the banter in the industry press that we may see some additional information coming out of CMS this fall, as early as this fall, on additional clarifications and potentially additional requirements. So, watch this space. Another question from the audience: what digital capabilities are most important for immediate investment in the Medicare space? What digital capabilities? Beth, you have any thoughts on that?
Well, I think that I guess twofold. Number one is, as Mike has pointed out, before you invest in any tools, make sure your data is clean, make sure it's actionable and usable. And then I would just say anything that can, as you think about it, most consumers actually want to self-serve first. They would like to be able to get their answer without having to pick up a phone. And despite the fact that we think that people over a certain age have no technology or don't use technology, a lot of them actually do, and a lot of them have phones that are capable of some type of simple interaction. So I would step back and just say, look, how are people reaching me now, and what are we seeing in other industries that people are using? You can snap a check and deposit it, right? So what is the equivalent? And a lot of people are doing that of all ages. So what is the equivalent in the healthcare industry? And I wouldn't be afraid to ask my consumers and go out and observe what it is that they are using, and then determine how that's really portable. I just wouldn't make assumptions that because we're trying to reduce, oftentimes as a health plan, we try to reduce our costs. And so we say, oh, well, this is what must be digitized, so we don't have to take a call. And what we should really be thinking about is, what are the things that the consumer really does want to self-serve on? And if they don't want to self-serve on something, why is it? Is it because there's a barrier? So it's not just about the tools. Make sure you're really looking at the underlying process as well. Because you can put up the tool, but if you haven't changed the process and it's not simplified, and they have to pick up the phone and call anyways, you spend a lot of money for nothing.
Yeah, very good. I also have a little bit of a different angle on that as well. And when I think about digital capabilities in the Medicare space, is how can you automate with technology? And I know one of the things that we're very focused on is the ability through that provider engagement tool that I referenced earlier to message the physician at the point of care embedded in the workflow of their electronic medical record, to be able to communicate things like gap in care closure possibilities right there prospectively when they're with their patient, either in the quality area or the HCC coding area. Quality area affecting your stars ratings and coding opportunities that will affect risk adjustment. So though there's another angle in terms of providing immediate investment in digital capabilities in Medicare.
Yes, I just tell them, don't forget, providers are your customers as well.
Yeah. One other one that Mike, maybe you might have the answer to this, we might not have the answer, and that was what will be the penalty of the CMS mandate? What will be the financial implications for payers? Now, I have not read anything specific that's been published yet. It could be that I missed it, but I do know that in prior kinds of mandates that CMS has penalized payers based on sort of a members per month or that kind of a mechanism. But Mike, have you heard or read on this, the interoperability regulations, whether they published any penalties for non-implementation?
You would know better than I would, JP. I haven't heard anything. I would be kind of hard pressed, giving some of the vagueness in the rule, that they can be too strict at the beginning, but it's anyone's guess, and I wouldn't be the right person. Yeah.
Yeah. So, like I said, we have not read anything specific. All we can point to is how they've addressed past issues. And there probably will be, but we don't know the extent or the magnitude. I watch the space, I guess. I think with that, we've covered all of the questions. And in fact, we did it in 59 minutes. So perfect timing. Listen, I appreciate everybody's participation. Thank you, Beth, and thank you, Mike, for providing excellent insights today. And we look forward to connecting up, and everyone have a great day today. And that'll be a wrap for this webinar. Thank you.
Thanks, JP.